talking for a while, and it's great to finally have you. A little bit about Ed. Ed was diagnosed with scleroderma in 1990, and he is the founder and CEO of the Scleroderma Education Project, a nonprofit solely focused on the systemic forms of scleroderma with a primary mission of education, from basic information for patients and families, members, to advanced information that can be useful to clinicians who are not scleroderma specialists. In addition, the Scleroderma Education Project is also advancing research that is focused on better understanding the early stages of the systemic scleroderma disease process, with the hope that this might lead to new treatment approaches. In March of 2018, a major review paper titled Therapeutic Plasma Exchange for the Treatment of Systemic Sclerosis, a comprehensive review and analysis, was published in the Research Journal of Scleroderma and Related Disorders. Ed was the lead author of this paper. He is currently working on a follow-up research paper that will explore the background, research that may explain how and why therapeutic plasma exchange leads to symptom improvements documented in this recently published review paper. Ed's going to be talking to us about this very subject, therapeutic plasma exchange for the treatment of systemic sclerosis, also known as TPE. And once the lecture finishes, we're going to open the floor to question and answer. Everybody can use their chat box, and you can type in all your messages. And once we're done, I'll read them off to Ed in the order that they were received. But again, we're going to wait until he's finished in its entirety. If people aren't already muted, if you can make sure that you are, so we can keep it quiet for Ed during his presentation. And I want to remind everybody that we're also going to be keeping the meeting open for about 30 minutes afterwards, and just try to see if we can share a little bit and have everybody share their name, how long they've had scleroderma, maybe what support group they're with, and maybe just something positive that you can share. And we'll try to keep it as brief as possible to give everybody a chance, but something that leaves us with a nice smile on our face when we're done. I want to remind everybody that the Scleroderma Foundation does not endorse any specific treatments, drugs, or research trials. Because scleroderma affects all patients differently, treatment approaches that may be appropriate for some patients may be less suitable for other patients. So any treatment decision should be always based on the knowledgeable discussions with patients and their clinicians. And without further ado, it's my absolute pleasure to introduce you to Ed Harris. Thank you, Ed.
Well, thank you for inviting me. Hopefully you can hear me. Tina asked me to just expand a little bit on her introduction, which I thought she did an excellent job. I was diagnosed with what was called CREST syndrome in January of 1990, but was symptomatic going back to 1985. I progressed very rapidly, and by early 93, I was not in great shape. And through what feels like a movie plot, which I won't go into, I ended up with the ability to review all the published research, this is before the internet, so it was a bit challenging. Discovered some research that was done fairly recently in Europe that led me to formulate a new disease model and potential treatment approach based on this disease model. And the bottom line is it worked. And I've been on this treatment ever since. A few years later, I started focusing on education. I actually worked extensively with the Scleroderma Foundation back in the mid-90s to late 90s on revisions to my very minimal website back then. And about 6 years ago, I decided to start focusing on research to see if we could understand the mechanisms of action of this treatment approach and see whether it might be beneficial to other people. That led to me presenting several posters at research conferences, including the American College of Rheumatology meeting, and ultimately led to the review paper that Tina mentioned. And we have a few other publications since. We'll talk about this a little bit, but at this point, I'm not the only person on this protocol. There are several other patients that are currently on it. So let me attempt to get the presentation going, which can be challenging. Oh, one thing that I didn't mention, the research I was doing led to me to get an appointment as an honorary research fellow at the University of Wisconsin in the rheumatology department, which has been extremely helpful in my being able to reach and communicate with other researchers. So the topic of today's presentation is an experimental treatment for systemic sclerosis called therapeutic plasma exchange. And if this is a link to the handout, but I think Tina sent the handout to everyone. But
I did.
If you want to copy this down, might be useful because you can share it with other people. It's just sclerodermainfo.org/PDF/handout you can see it.
If I may interrupt, Ed, I did. Yeah. I sent them actually both, making it easy. If they wanted to download your handout, I gave them the download as well as the link to click on it directly. And if anybody didn't get it, just let me know and I'll be happy to provide another copy.
Excellent. Thank you.
Thank you. I'm sorry, Ed.
Yeah, no problem. Okay. You folks are very knowledgeable on systemic sclerosis and understand a lot of things about it, so I won't go into basics. But it's important to understand that systemic sclerosis has the highest mortality rate of any autoimmune disease. Standard treatments are primarily symptom-based. There was a very interesting study published a few years ago which looked at survival improvements over the past 40 years and concluded that, yes, while patients with scleroderma are now living longer than they did 30 or 40 years ago, so is everyone else. And if you actually look at relative mortality rates, back in 2012, there was no improvement in survival, suggesting that the current treatment approaches are really not very effective. I just added to this slide the autologous stem cell transplants. In some cases, turn out to be a very effective treatment, and then hopefully you guys can have a talk on that sometime. It's something to consider, but it's mostly restricted to high-risk patients for a number of reasons. So the topic today is a treatment called therapeutic plasma exchange. And it's actually a very, very simple concept that's been used since the 70s. Basically, the idea is if there are molecules such as antibodies or other pathogenic molecules that are circulating in the blood, if you can eliminate some of these or most of them, it may lead to improvements, which in fact is the case in many diseases. So all that is done, it's a procedure where 2 needles are inserted, 1 in each arm. Blood is withdrawn. It goes through a centrifuge, which separates the plasma, the liquid part of the blood, from the red cells, white cells, and platelets. The plasma is discarded and replaced with something, either fresh frozen plasma or sterilized albumin. This, by the way, is kind of curious. If you've never seen what plasma looks like, that's pretty much the exact color of plasma if you eliminate the red cells and things from it. So kind of interesting. The replacement fluid is typically either sterilized albumin or, in some cases, fresh frozen plasma. It is safer to do it with albumin. We'll get to that later. A typical treatment takes about 90 minutes, but it's totally based on your body weight. It can take less or more time. And it's a pretty straightforward procedure once the needles are in and it's going. This actually shows what someone typically might look like, resting comfortably, watching a movie, hopefully an action movie. I can explain that. There's a reason for it medically. And that's it. It's not that difficult to go through from the patient's perspective. Okay, so here's something that you need to know. Therapeutic plasma exchange is not an experimental treatment at all. It's experimental when used to treat systemic sclerosis, but it's a very commonly used treatment for a variety of disorders. Most of them are neurological disorders, blood disorders, and renal. So it's a mainstream treatment for a lot of diseases, and I've listed some there. So what we're really talking about here, you can think of as an off-label use of a commonly used treatment. So I'll go through this pretty rapidly. This is a brief summary of the paper that was published in 2018 in the Journal of Scleroderma-related Disorders, which Tina mentioned. We were very careful. We knew this would be controversial, so we were very careful to do this right. And so we used standard rating systems as we were reviewing the articles, and we had two people independently grade the articles using these standardized checklists. So we were very careful to make this study as well designed as possible. Here's an overall summary, and this is worth taking a second looking at for a couple reasons. One, if you'll see, there's 46, at the time this research was published, there were 46 published papers on the use of therapeutic plasma exchange to treat systemic sclerosis, going back to the late 70s. And out of those, there were a total of 455 people that received a TPE. So that's a not insignificant number of patients if you look at research for things that are experimental. There have been a few randomized trials, but that was not very common, and most of those were done a few years ago. You'll see that there were 19 case reports. We'll talk about some of those. But I wanted to mention this thing called pre-post study with no control group, because you'll see there are a lot of the studies fall into that category. And scleroderma is an interesting disease. It's one of the ones where it doesn't go into remission like you see in diseases like multiple sclerosis. And because of that, a top researcher I was talking to said you can do early research pretty effectively without a control group. Because if you know that patients are not going to get better on their own, and maybe they are stable, if you take patients, a group of patients, and you add a treatment and they get better, it's a reasonable assumption with this disease that it was probably a result. And a top researcher who told me this is unusual, but this is one disease where you can weight this kind of study much more than you would, let's say, if you were studying multiple sclerosis. So I wanted to mention that. So one of the problems in a lot of research is researchers like to do multiple things. It's very common. And we saw this quite strongly. And if you look, out of the 46 studies, just about half were treatments using TPE alone. The rest of them were confounded with the use of immunosuppressants or all sorts of other things. And so even if the patient got better, we didn't weight these studies very highly, because even if it works, you don't know what caused it, whether another component or synergy between them. So we focused primarily on the 25 that were TPE alone. And here's a basic summary of what we found, that most patients received TPE regardless of the protocol, showed improvements in both laboratory markers and signs and symptoms, whether it was a short-term acute usage or longer term. This second bullet is interesting. More than a dozen papers mentioned that they started to see rapid improvement in Raynaud's after like 3 or 4 weekly TPE treatments. And I actually presented a poster at the American College of Rheumatology in 2016 on this topic. And these patients, even if they'd had digital ulcers which weren't healing, started to see healing occur. So that was an interesting finding that a lot of 12 of the papers actually mentioned. And the other thing that needs to be considered, systemic sclerosis is a chronic disease, and pretty much any treatment other than stem cell transplants potentially has to be continued or you will relapse. At least that's what we found so far. So TPE is no different than any of the other common treatments, and that's something that you need to understand when you're looking at a treatment like that. One of the things that people are concerned about when you're doing this type of treatment is, are people's veins going to be good enough? And what overall, about most of the patients in these studies were able to do this with just normal veins, arm veins. Some could not. Some of those patients were discontinued, and some were given ports. But it was not something that, in most cases, they had to go to some type of port to do TPE. TPE was very well tolerated. There were no reported deaths. The side effects were minimal and short term. The research indicated this was found to be very, very safe for pretty much everyone, whether they were in earlier or later disease states. And that's an important thing to think about. Most of the research where it was stated what kind of diagnosis the patients had was actually done on diffuse rather than limited. But there was about a third of the patients, or a little higher than that, it didn't even indicate whether they had diffuse or limited. Some of them predated the 1980 diagnostic classification, so that's not surprising. And the protocols were all over the map, depending what they were trying to do. So we were unable to do any protocol-based comparisons, unfortunately, in this review. Mixed connective tissue disease, 6 of the case reports were on MCTD, and most researchers classify this as a Scleroderma family disease, even though there's overlapping symptoms that are seen in lupus and rheumatoid arthritis and myositis. Most of them were short-term interventions, but one was very interesting. This was a 12-year-old with MCTD who basically went into full remission. They were able to drop prednisone, and she remained in perfect health for the 2-year period of this study. At one time they were late with it, and she started to get some breakthrough, but that was an interesting study. And it's particularly relevant because I was on the phone for about 20 minutes yesterday with a doctor, pediatric rheumatologist, who has a 14-year-old patient with MCTD, and they are considering a trial of MCTD. So we talked about this case and the protocol and potential issues. So kind of interesting timing. And this is important to know. No treatment works for everyone. This was not effective, they found, if patients went into scleroderma renal crisis. This was tried before they had ACE inhibitors, and ACE inhibitors are much more effective. It just was not effective for dealing with SRC. If patients were in very late stages, this is used as a last resort. Lungs were failing. Most of the time, it made no difference. But pretty much everyone said, and this is probably true of a lot of treatments, TPE should be started relatively early, ideally, to be most effective. Not too surprising. So one of these, after looking at this, there's an obvious question: what would happen if you were using TPE as a treatment over a very long period of time? And at the moment, there's only one case report published. I'm the lead author on that. And as you can see, this was published a few years ago. This was 22 years, which is, in medicine, 2 years is long-term, 5 is very long-term, and it's pretty rare to see something like this. But the bottom line is, in this particular case, this was the only protocol used. The patient was centromere, diagnosed in 1990, CREST syndrome, rapid progression. Does this sound familiar? This is me I'm talking about. And one thing that's very important is I was starting to have deterioration of my lungs in a way that's typical with this antibody. The lung risk with centromere antibodies is primarily pulmonary artery hypertension, as some of you, I'm sure, are aware of. And one of the markers that the clinicians will look at is DLCO or DLCO-VA. I won't go into what it is. Mine was already dropping. It wasn't quite at the range where they were concerned that I had active pulmonary artery hypertension, but it was being watched closely because if it dropped much more, I would be looking at a right heart catheterization. So that was a symptom. I also had severe GERD, uncontrollable on high doses of proton pump inhibitors and so forth. late 1993, I managed to get approval to have this covered by insurance, which is amazing. Started a particular protocol that's documented here, late 1993, no other systemic interventions going on. And what happened is after 1 year, it was very clear that we were seeing significant improvements. GERD was much better, but still there. Raynaud's was much better. Chronic chilling was gone. So we got approval to continue it for another year. And at 2 years, the GERD was completely gone. Pretty much the only symptom was left was very, very, very mild Raynaud's. That's it. And everything else had disappeared. The DLCO had stabilized. It wasn't dropping any further. And we tracked that over the next few years and saw it gradually increase. And at 2001, which is the last time it was measured, it had actually returned to the normal range. So we saw a reversal of objective lung function markers, which is kind of interesting. And basically, that's my current situation. I was playing tennis every day until the pandemic hit, but at the moment I'm not. That's pretty much been it. If you look at the fourth bullet, at one point we stopped this to see what would happen. And what happened is I started becoming symptomatic again. And I started developing severe GERD about 6 months later. And it took a while to go after we went back on for that to go away again. So I didn't like that experiment. It was not voluntary on my part, I will say. Now, I don't know if the bottom of the slide is messed up on mine, but a second patient has now been on this particular pulsed plasma exchange protocol for about 2.5 years. She's in Europe. She has a rare diffuse antibody, U3RNP. Her most severe symptoms, she had early stage, were severe pain and fatigue, which is not uncommon with diffuse scleroderma, as I'm sure many of you have experienced. Well, it was interesting. After the first round of 4 weekly treatments, she noticed significant improvement in her pain and fatigue for a while, but it started to come back about 6 weeks later, 2 weeks before the second round. After the second round, they never returned. And after about 9 months, she reported being in full clinical remission and has remained in that state. She's playing sports 6 days a week and totally symptom-free, and is continuing on a protocol, except for COVID-19. And one of the interesting things that happened is it gave us a little bit of an insight as to what happens if you discontinue. And both in my case and her case, because of the fears of going into a hospital with COVID, she's in Europe and having it done at a Johns Hopkins Associated Hospital in Turkey, actually, we both stopped. And what happened is that about 2 months after we would have had another round, both of us began to get symptomatic again. In my case, very, very mild early GERD. I could recognize it earlier. In her case, for the first time in 2 years, she started to experience some joint pain. I'm back on the protocol. She started this week, and mine is already resolving after 1 round. I'll be very interested in seeing what happens in her case. But this is kind of an interesting situation that reaffirms this is a chronic treatment for a chronic disease. And before we get into this, I will mention there are currently 3 other patients on this protocol, all in the US at the moment, although I'm working with a patient in Egypt who may start soon. None of them have been on for very long. One literally just started 3 weeks ago. Others have gone through either 2 or 3 cycles. Interestingly, both of the patients noticed the significant improvement on Raynaud's after the first round. So that's, again, quite consistent with the research literature. And I tend to not track it too closely early on because placebo effects are incredibly strong. I'm more interested in objective markers, which we are looking. Everyone is using the exact same protocol and test, so we'll have a pretty good idea about this when we're done. There are several other patients that have been approved for starting. Patient is getting ports installed on Monday. We'll be starting immediately after, and I know of 2 others that have approval and they're working through logistics, and we may have the mixed connective pediatric, though that's still in early stages. So it's no longer just myself or one other patient. So one of the things that bothered almost every researcher back in the early 80s, even late 70s, is they would do a few treatments, they'd see benefit, stop doing the treatments, and the benefits lasted sometimes for months, which made no sense. And the reason why it made no sense, the normal usage of therapeutic plasma exchange are as an acute intervention, where you really are looking at trying to rapidly reduce antibody levels or doing something else. And antibody levels actually return very quickly after a single TPE treatment. At 3 days, they're actually about 90%, and at 1 week, you can't detect any differences. So they were very puzzled about the longevity of the effects. So the question is why? There were some researchers in Europe, mostly out of the Netherlands, which actually started to look at this and decided that part of the explanation this may be related to abnormal blood rheology, and rheology is just a medical term for physical properties of blood, like how thick it is, viscosity, and so forth. And they began to notice some very interesting things about blood in patients with systemic sclerosis. If you look at patients, and many studies have done this, blood is actually highly abnormal. The overall blood viscosity is elevated, so it's abnormally thick. And there are numerous reports in patient support groups of people who used to donate blood before they were diagnosed. And before this came up or became even symptomatic, they started getting complaints from the people doing the blood draw saying, your blood is really thick, it's taking forever. And I've seen this 24 times over the years in groups. That's what this is talking about. The nature of blood can be thick for a number of reasons, and often it's related to clumping of platelets. This is not the case here. What is going on that's leading to the abnormal thick blood appears to be the red blood cells clumping together. And they're also not as flexible as they are. We'll talk about that in a minute. Here, the third bullet's interesting. One of the things that they looked at, it turns out if you look at patients with primary Raynaud's, this is Raynaud's that typically starts teen years, blood is pretty much normal. But if you look at the blood of patients with systemic sclerosis, as I mentioned, it's highly abnormal. And I actually had a letter to the editor published in Clinical Rheumatology of about 6 months or 9 months ago, talking about this in response to a paper on Raynaud's. And two recent papers in the past couple of years have documented a significant correlation between digital ulcers and elevated blood viscosity in one case, and elevated blood viscosity in pulmonary artery hypertension. And these are recent papers. And this is interesting. I just found this paper 9 months ago. There was a very early paper talking about this whole issue of the red blood cell aggregating together. And if you look at the top two pictures, it is actually in a lot of diseases, red blood cells do clump together. The technical term is aggregation. And they form into linear stacks called rouleau stacks or rouleau formations. You'll see this in lupus, you see it in rheumatoid arthritis and other diseases. One of the interesting things about these is these rouleau stacks break apart very easily and reform very easily, very quickly. What this author back in the 80s noticed, because they were looking at the properties of the red blood cells, that the aggregates of red blood cells were highly shear resistant, and that means they did not break apart very easily. And that's all they said about it. And actually, my 1993 paper that got me approved for this speculated that there were clumps that were tightly bound. And I just found this. It's a 1999 paper published in France, where not only did they see the same kind of thing, but they actually documented and took photographs of the clumps. And these, you see that the rouleau stacks are there. But in addition, I circled them. Those are nonlinear, that is, they're not part of the rouleau stacks, clumps of red blood cells that are tightly bound together. So this is what I proposed in 1993, and we now have photographic evidence that in fact this exists. So why is this important? Back in '79, some researchers and key researchers in the field actually became aware that this disease seems to be a disease of the microvascular system, and that if you start with the inside of the blood vessels being damaged by something, they could, even back in '79, without understanding things fully at a molecular level, they could pretty much account for everything that occurs in systemic sclerosis, the fibrosis, the organ damage, and things. But one of the comments they talked about repeated insults to the insides of the blood vessels for reasons they had no clue, but then they could sort of say everything happens with that. And I've gone to several presentations where you'll see a diagram which will say endothelial or microvascular damage, and then they go into all these wonderful things that happen, which are leading to a whole bunch of drug targets for various phases of fibrosis. So that's all kind of interesting. I saw when somebody presented that at the conference. So let's kind of look at this from a theoretical perspective. And I will say right here, everything that I'm saying is hypotheses. It's consistent with the research, but we have not formally proved that this is what is going on. And in fact, there's likely to be other things going on, but this is what may be a significant part of the pathogenic processes in systemic sclerosis. So this shows kind of what happens normally. What you may not be aware of is the smallest blood vessels are smaller than the diameter of a single red blood cell. And in order for them to get through, they have to kind of stretch out and fold. So, and they do, and everything works quite well. But that's an important thing to know. So what would happen, theoretically, if you started to get even small clumps of red blood cells that were tightly bound? And the rouleau formations that I mentioned break apart pretty easily with normal blood flow. But let's suppose you have something that really doesn't go through very easily. If it's small clumps, the blood vessels are pretty flexible, and many of you are on drugs that make them even more flexible. But over time, it's kind of reasonable that they may cause some damage to the inside. Remember the repeated insults comment in that 1979 paper. So that might happen, and if the clumps are small, you could get kind of slow damage over a long period of time. So think about what happens with limited systemic scleroderma, where most of the time you get Raynaud's for years before you see anything else. In contrast, let's look at what would happen. Suppose you have larger clumps of, again, tightly clumped blood cells. Well, one of the things that could happen, and does happen in other diseases, and I'm going to use sickle cell anemia crisis as an example. When you have sickle cell anemia crisis, the deformed blood cells clump together and they block blood flow. And what are some of the key symptoms you see in sickle cell anemia when this occurs? Severe pain and fatigue. And actually, Dr. Tracy Freck was one who pointed out that in her practice, a lot of the time, the initial presentation of diffuse, even before Raynaud's, is severe pain and fatigue. So again, this is hypothetical, but it's consistent with what we know about what happens with certain kinds of abnormal blood rheology. And so if you do something where you can prevent the clump red blood cells, the idea is you should have no further trauma to the microvascular system, and over time things should heal. We all know the body is extremely capable of healing. So that's kind of what this is basically what I was proposed in 1993. So a key paper behind my speculating this was done in 1991, and if I can manage to get a laser pointer, which I may or may not be able to do, and I'm very good at this, let me try. Yay, that worked. Okay, so the research group that was doing all this work in the Netherlands in the 80s and 90s that was documented the abnormal blood rheology, they noted that plasma exchange does nothing for primary Raynaud's, but was dramatically effective for secondary. So one of the key studies was a 1991 paper where they closely were looking at the physical properties of blood. They were directly measuring whole blood viscosity and red blood cell aggregation, which is pretty difficult to do, by the way. And what they did is they did 4 weekly TPE treatments and then stopped and observed. And they actually measured changes in both red blood cell aggregation and whole blood viscosity after every treatment so they could see what happened. And this, the first part of this graph, I just chose the red blood cell clumping. So the red blood cells were clumped, and the measure they used, I don't know if you can see the number, was 25 based on the instrument they were using. And that was kind of the average of the baseline of this group of patients. And basically, if you look at what happened on a week-by-week basis, after the first one, you saw like a 50% drop in the red blood cell clumping. Didn't see as much in the second. But after 4, the blood clumping and the overall blood viscosity was pretty much indistinguishable from normal blood. So that's interesting, maybe not surprising. But they then started to track what happened, and I wish they had done more tracking, but they at least did some. 3 months later, that's this point right here, the red blood cell aggregation was still half of what it was before they started TPE 4 months earlier. So this is something going on which is kind of interesting and may be related to the very long-lasting effects with plasma exchange. And this is what we kind of extrapolated. I extrapolated the lines to suggest that somewhere around 4 to 5 months out, probably it would be back to baseline, but they only did a measurement of 3 months and 9 months. 9 months, it was totally back to pre-TPE levels. So that's a guess. It may have been different from that, but in any case. So that's kind of an interesting part of this. So here's the working hypothesis for what may be going on with plasma exchange. And here I'm going to introduce a new term, which we're using more and more. Here I'm calling this pulsed TPE because the protocol that we are suggesting patients use is a pulsed protocol. And all that means it's a protocol that starts and stops. This is not a every 3 weeks you do plasma exchange kind of protocol. And here's what we're looking at. So the idea is if you do 4 weekly TPE treatments, we know from the one study your blood should be pretty much normal. And if you then wait 8 weeks, it'll still be not that abnormal, but it's going to be headed back toward it. So, and this was the 3-month point. This is the 8-week point. So the idea is what you would expect to happen is if you at 8 weeks out, then do another plasma exchange cycle, you're not going to see it go up. It'll drop again. Then you stop for 8 weeks, goes up, blah, blah, blah. So you see a sawtooth pattern. That was what we assumed would happen if you do this. And then what might be the case, and this needs a lot of research to look at it, we have here a green zone, and pay no attention to the absolute size of it. But conceptually, what this means is maybe there's a certain level of treatment or treatment interval which allows your blood to begin to become abnormal, but not get to the point where it's really going to be problematic. And if you can do this often enough to keep it in this green zone, you should see no further damage to the endothelium, and theoretically, if you don't have any damage to the endothelium, you should see no further fibrosis, systemic organ damage, etc., and that should lead to slow, gradual healing. That's the concept. And I drew it this way for a reason, saying that, the last week or so, you may be getting near that point. And remember what I said, what happened when the two of us dropped for 2 months? And we both started to become symptomatic. Well, if you follow this protocol, that meant we were back in this zone, not in the green zone anymore conceptually. and symptoms started to return. So I was expecting that fully. I just didn't know how quickly it would happen. And I did not know what would happen in case of this patient with diffuse, and they're a totally different symptom profile. Okay, so that's the theory behind this. So here's the obvious questions that stem from any discussion like this. How safe is this? And I will tell you up front that rheumatologists in general do not use TPE, and many of them are afraid of it. They don't understand it. They think it is very dangerous, very hard to do, and if you're dying, we might try it. This is actually a reaction that we've got a lot of time, and this is just because they're not familiar with it. But as I mentioned before, this is actually a first-line treatment. It's a gold standard treatment for, however you pronounce it, Guillain-Barré and hyperviscosity syndrome. That's interesting. It's a gold standard treatment for symptoms which are characterized by abnormal blood rheology. We discussed this in the paper. And this is pretty typical of major reviews. This study looked at 2,700 TPE procedures. There were adverse events in 3%, all were mild and transient. The cases where it was most severe, without exception, was where they were using fresh frozen plasma to replace the plasma that was discarded, rather than what we recommend is sterilized albumin. And the reason is, if you're working with blood products like fresh frozen plasma, you're more likely to get an allergic reaction. In the 30 years they've been doing plasma exchange at the University of Wisconsin, they literally have had only one person who was allergic to albumin. So it's really a very, very safe thing. Now, in many of the acute treatment protocols, you actually have to use fresh frozen plasma, because when you go through a treatment like this, you temporarily reduce clotting factors and other things. But if you're doing it at the protocol level that we're talking about, it doesn't reduce, it doesn't depress the immune system, and it doesn't have these effects. So there's no functional reason to use anything other than fresh frozen plasma. So what are the risks? All of you are aware that the standard medications used for systemic scleroderma, especially the immunosuppressants, methotrexate, Cellcept, Cytoxan, or whatever, these are immunosuppressant drugs, have some significant risks, partly dependent on the dosage and then partly depending on the meds. So they're not that safe a treatment in many ways, but if that's what you've got, you take the risk. So at this point, the only known risk of long-term TPE, and this is documented, is that you will develop, not may, you almost certainly will develop very mild iron deficiency anemia. And it is easily treatable with over-the-counter iron supplements. If you can't tolerate those, and some people can, then they use infusions of iron while you're already hooked up after you finish the TPE. Most people can take over-the-counter. I won't go into the explanation, but if anybody's interested, I can tell you exactly why that occurs. And it actually may indirectly be part of the reason why TPE works the way it does, interestingly. So, venous access is a real issue. The best way to perform TPE is using regular peripheral access. And if for those of you who have a little bit of understanding of medical terms, one of the two veins used if you're using arms it's called an antecubital vein. And this is the vein that's on the inside of where your arm bends. Those are big veins, the main antecubital, and there's two other ones, and I can never remember the name. The IV that's used for blood draw has to have that level of vein. So you need one good antecubital. The return is much smaller needle, and lots of veins work. So if people have problems, typically they don't have a good antecubital. Now, a major study found that with long-term TPE, about 75% of the time, people can do this with just peripheral normal venous access. I've been doing it for 27 years, 425 treatments just with veins. Many people can do that, but not everyone. And in fact, one patient before starting TPE, they know her veins are not good. She's just getting a port implanted. But they're better techniques than when this 75% number was around. There's a really cool system called Vein Viewer, which some of you maybe at hospitals will have. It's a $20,000 toy. Basically, it's a light that shines on your arm and shows you exactly where the blood vessels are. And it's a major advance for infusion nurses inserting IVs. And if they fail, large hospitals may have ultrasonic guided systems which work great to do that. So, but you may or may not have those. But the bottom line is there is a subset of patients that we don't know the percentage yet that will not be able to do TPE unless they have a port installed. And while short-term ports like central line catheters are often used for short-term TPE, this is not a good idea for long-term. There's too much infection risk. It just isn't done. But the good news is there's a number of surgically implanted vascular ports on the market that can be used for this. One of them is actually specifically approved for TPE. And what I've read is that for people who have these, it makes TPE a heck of a lot easier. And these are the sort of thing where you can go swimming and so forth. They're pretty easy to deal with, and there's very rarely any problems with them. But that's what clearly some patients do have to do if they're going to underdo that. And I suspect some of you may have these ports implanted if you're getting IVIG regularly or certain infusions. It's pretty common to have ports like these implanted. All right. Costs. I do not know why I'm not seeing my slides. Yeah, there it is, back. It's very strange. So people are concerned about cost. So the reality is a TPE treatment costs on average about $1,200. And that's in fact what Medicare reimburses. And that'll vary. If you're larger, it'll cost more because you'll need more albumin. Now, what your hospital will want to charge your insurance company, multiply that by 3 or 4, like everything else that they do. But that's the real cost, is about $1,200. And this protocol that we suggest costs, in reality, about $20,000 a year as a pricing a couple of years ago. Originally, when I did this slide, Humira actually was costing about $22,000. That was 2 or 3 years ago. The prices have been bumped, and the last time I checked on this, which is a few months ago, the annual cost for Humira, which is a drug commonly used for rheumatoid arthritis, is $51,000 a year. And IVIG, which I'm sure some of you have tried, is extremely expensive. Averages, I've been, according to the research, about $10,000 a month. And there are problems getting IVIG. So cost-wise, yes, it's not cheap, but it's certainly not out of the range of what is pretty common in this day and age. So that brings up the question of insurance coverage, obviously. 5 years ago, almost no insurance companies that we checked with covered TPE for therapeutic, covered TPE for systemic sclerosis. Medicare actually did. The criteria was that other treatments were not working and that you had significant mortality risk, which is not a particularly hard barrier to meet. But when we checked, almost no insurance was covering it. Interestingly, when we checked about a year ago, a year or so after the paper was published, suddenly we're finding that the majority of insurance companies are covering TPE, sometimes with prior auth, sometimes without. Now, we don't know why that occurred. We all know that insurance companies like to make things often become more generous and offer more coverage for people. And so maybe that's what was going on, or maybe it indirectly related to the paper. But for whatever reason, we're finding that most people who check with their insurance companies are learning that it is covered. Now, I will tell you, since we're talking in California here, Kaiser is one of the groups where it depends on your plan, and some plans are not covering it, some are. So it's not as, doesn't seem to be as well covered by Kaiser as most other ones, but we are finding most are covering it. And this is in the handout. If you want to find out, it's really easy. You call your insurance company, you ask, do you cover therapeutic apheresis, CPT code 36514? for the treatment of, and here you use whichever one you're diagnosed with, M34.0 if you're diffuse or M34.1 if you're limited, the ICD-10 code is, and you give them that. And they love that because then they go look it up on the table and they will be able to tell you in most cases very quickly whether they cover it, under what conditions, and so forth. And so this is not something we expected to change that rapidly. I'm kind of surprised that it did, quite frankly. And so if you are interested in trying this, we recommend a 1-year commitment and trial to see if it's going to work. If you have no improvement after a year of this, it's extremely unlikely that longer would do anything. So that's kind of our general comment on it. But remember, this is a very, very safe treatment compared to a lot of the things that many of you are on. So that's a factor that you have to weigh in. We are seeing that even a single round of treatments can show benefit for some people. And I'm working with a patient now who has just had her 7th finger amputated, and she has limited. She was actually in the poster I presented at ACR that there's a picture showing the progression from normal hands to loss. She was my hand model in that paper. Anyway, she's now actually going to try and start TPE to see if she can save her remaining fingers. The data that we saw in my own case is you really, if it's going to work, you're going to see significant improvement in that year, but you're not going to be seeing full remission. It depends on where you are. If it works, you're not going to see everything healed at that year. It took 2 years for me to get my GI symptoms totally under control. And an interesting side on that, I've been looking at the research on the effects of successful autologous stem cell transplants on GI symptoms, and not a lot published on it, but I've talked to some of the people doing this research. And interestingly, what I'm hearing is they're seeing about a year and a half before patients start reporting major improvements in GI symptoms, even if some of the others were more rapid. So one possibility is this takes time for the GI tract to rebuild itself, might be in the 1 to 2 year interval. So, and the reason I bring up HSCT, autologous stem cell transplants, is even though these are wildly different procedures, successful stem cell transplants really interrupt the disease process at a very early stage using a completely different mechanism here. It's an earlier stage than this is targeting. If this is doing what we think it is, which is preventing endothelial damage, it is also interrupting the disease process at a pretty early stage. So there might be some parallels in what happens in terms of some of the symptoms to that. So again, it's a hypothesis, but it makes some sense if you think about it, and it's consistent with the data that we're aware of. Okay, how long does TPE need to be continued? Well, I think we've addressed that. It's a chronic disease. It needs to be a chronic treatment until something better is available. So if they could figure out how to easily do stem cell transplants safely and make it work for everybody, that would be the way to go. My research is actually not focused on this treatment other than as an interim. Basically, what I'm interested in looking at is if we can verify that the hypothesis is correct, then anything that can break apart the red blood cell clumping should be beneficial. And COVID actually interrupted. We were just about to do a pilot study of something, I won't go into it, but a pretty straightforward treatment that is known to improve red blood cell aggregation. And we were going to do a pilot study to see whether it also improved the red blood cell clumping. And there's a couple drugs that would be very interesting to try as well, because they're, again, known to break apart the rouleau stacks. Whether they'll have any effect on the red blood cell clumping, that we can find out, but we don't know. But that's the real goal, because if we can figure out what's going on, that gives us targets, and including drug targets, for keeping the maybe much easier ways to break up the red blood cells. And so you might eventually get to the point, I hope, or you might start with a single round of TPE to get the blood normal and then go on a drug that can prevent it from reclumping, assuming that is what is going on in this disease process. And I've kind of described that. It's really very easy to go through most of the time. Occasionally, veins can be difficult to access, so you get used to it. Once the veins are in, it's going. It's little pain and discomfort. It's quite easy. One of the short-term mild things that happens with plasma exchange is blood pressure tends to drop. And 12 years ago, it dawned on me, well, what would happen if you watched a movie like Terminator, Aliens, a horror movie, something that stimulates adrenaline production? And so we experimented, and lo and behold, if you actually watch something that stimulates adrenaline, the blood pressure drop completely disappears and can actually sometimes go up. So that's kind of an interesting thing. So when I said watching an action movie or something, there's actually a medical reason for that. It eliminates one of the symptoms that can occur, mild symptom, but it eliminates it completely. Kind of interesting. We've joked about if we get a lot of people in this, we'll start having a suggested library of movies to watch during TPE, but we're not there yet. So who can prescribe TPE? TPE is actually not FDA regulated. And basically, any ND or DO can potentially order TPO, but it depends on the hospital and clinic. There are some where if the patient is diagnosed with a rheumatological disease like Scleroderma, they require a rheumatologist to order it. Other places don't. If you end up under the care of a hematologist, by the way, they instantly understand what's going on with this, and they're very comfortable with TPE. So a couple of people who've gotten on this have actually worked with hematologists. Kind of interesting. But TPE itself is typically available in any large hospital. It's most often done at an infusion center. So if you're out in the rural sticks, you're not going to have access to this. And since you're talking about doing this 16 times a year, potentially long term, the access has to be something you have to think about. So this is not going to be available to everyone. So barriers to trying it, local access. There is a learning curve for rheumatologists in particular, because again, they're not familiar with TPE, and some of the patients who have approached it have gotten into it's way too dangerous. One of my favorites was somebody saying, you can't try TPE, it's way too new. It's been used since the 70s for a lot of things. A common reaction we get from rheumatologists, general rheumatologists, not specialists, but general rheumatologists, is it doesn't work. And we've had 2 cases now where a patient has asked a rheumatologist to read the research so they could talk about it. That's all they did. We've had 2 cases where the doctor literally said, I'm not going to bother to read the research because I know it doesn't work. You might need a new rheumatologist at that point, just my thought. So that's most of this. We have a number of additional documents. We have an overview of pulse plasma exchange for clinicians. It's a short one. The review paper is open access, so anybody can go onto the publisher's website and download and read the actual review paper, which is something you often can't do. We had to spend $3,400 to get that open access, and I think it was worth it. The long-term case report is readily available through the website. And 2 other ones, which I'm going to go a little bit more into the next slides, are worth mentioning briefly. We have a document called Suggested Protocol for a 1-Year Trial of Pulse Plasma Exchange. And this is a summary document for clinicians. It covers all this quickly. It goes through the recommended protocol. It talks about the tests that we suggest for managing, learning how it's working objectively. And there's 2 questionnaires we ask people to fill out. What we're doing is we're trying something which is not real common, which is to sort of start from day one, encouraging clinicians to think about this as part of a future case series, because what we'd like to do is basically see what happens if people are using this protocol. Again, this is considered to be a safe treatment. And if people follow the same protocol, mostly do the same testing, same questionnaires, that allows us to do a very powerful case series, which is frankly not that much different from an open label pilot study. And so far, that's what's happening. The reality is most case reports, I've been told, usually start by a clinician trying something novel. It works, and then they say, hey, that's cool, let's turn it into a case report. And then immediately say, I really wish we had measured X, Y, and Z. So we're taking a novel approach here, explaining the rationale and trying to encourage people, if they are going to use a protocol, to treat it as part of a future case series. And we'll document it, good, bad, or indifferent. And we're trying to advance the science here is one of the goals. The other document, which is really kind of an interesting one, about 5 years ago, I co-wrote this with the head infusion center nurse. Because when I started this in 1993, I was terrified. Nobody told me what was going on, anything. And so we put together a document called TPE, A Guide for Newbies. It had nothing to do with this disease. It's a general document explaining what's going on and trying to get patients that are more relaxed with it. And really takes you through, you're probably going to be tired for 12 hours, 24 hours later, you mostly feel back to normal. But I'll tell you from experience, if you play soccer the next morning after an afternoon treatment, you may get winded a little more easily than you would. 2 days later, you won't even feel it. So we cover all of this, and several patients have used this now, and it really, really helps. So that if for anybody who's going to be looking at that we really encourage you. And this starts by saying, before you even start this, you need to go visit the infusion center, have the nurses evaluate your veins, and they may tell you right now, you're going to need a port implanted if you want to try this, or, oh, you've got great veins. We love that when we see something like that. So all of this is covered in that document. And bottom line is, what we concluded in the review is that long-term TPE may offer a low-risk way to control and potentially reverse some symptoms. We don't know how many. We said very clearly, a lot of these 46 studies were not very high quality. Almost half of them confounded with other treatments. And literally out of the 46, only 10 got our top marks in quality. And the Scleroderma Foundation did a really nice job recently kind of summarizing the research on this, pointing it out. And so they did a great job. I totally agree with everything they said. One of our main conclusions was there's enough there, we think, to justify a cleanly done randomized clinical trial using modern TPE equipment, which I'll tell you is better than it was for most of these studies were done in the 80s and 90s, modern venous access techniques, and carefully monitoring things objectively. It's really justified. And I've heard from the grapevine, and there's some researchers who've read the research, at least agree that a well-done clinical study is merited based on kind of what we're seeing, and something I would love to see happen. But my perspective, as I mentioned, I think it's even more important in some ways to figure out what is going on, because if we can fully understand what it is doing and how it works, I think that will lead us to potential targets and drug treatments that maybe eliminate entirely the need for a treatment, or maybe you use it quickly to get things under control and then maintain it with drug treatment of some sort. So that is it. You've got this. My contact information is on the handout, so anybody can freely contact me.
Some questions up on the screen, but I also had a few that were texted to me, I think, from people that were using their phones. So I'm going to start with the ones on my phone. And do you have any evidence that TPE has any effect on the two leading causes of death in scleroderma, interstitial lung disease and pulmonary hypertension?
That's a great question, and one I get often. If you actually go through some of the studies, they have looked at interstitial lung disease and seen objective improvements in x-rays and things like that. And some of these were short-term and whatever. I didn't see anything that we reviewed which talked about pulmonary artery hypertension. That was not, none of the studies. And again, remember, the majority were done with diffuse, where ILD is more of a common, and limited where it's PAH. We do know, in my case, the DLCO improved, and that, of course, is a marker for the kind of changes that predate PAH. So the bottom line is, there is some evidence, objective evidence, showing improvements in ILD. Are really, if it's quite limited with PAH. We don't know. So I think that's likely, based on the fact that it does seem to lead to improvements in DLCO, that it would lead to improvement over time, but that's speculation.
Thank you. You mentioned 3 randomized trials. What were findings from those 3 trials?
Well, the trials, and none of those made it into our top category. A couple were pretty decent. In all cases, they were significantly, they did significantly better than a control group. One, it's been a while since I've looked at it. There was a Chinese study that used as a control group, I'm blanking on a drug that was tried a lot in early research. It was something that was experimented with a lot, and can't remember it. I'll think of it in a minute, but it was rejected. Doesn't work that well, and it was significantly better. The Chinese study was pretty good, but they didn't do long-term follow-up. They also used a very different protocol. So, but the other 2, I can't remember the specifics, but they're not impressive studies, and some of these were old enough to where I will flatly just say I'm not impressed with the research that's been done on date with randomized clinical trials. Now, I won't get into this here, but the randomized trial I would really like to do involves 2 treatment groups and a control group. The treatment group would receive regular TPE. A second treatment group would receive a modified version of this, where the plasma is actually not replaced, but instead your own plasma is recirculated back in. And that conceptually makes a very logical control group. There's one little problem, and that's why I would love to look at this. There was a research group that looked at that. And interestingly, the group that didn't have their plasma replaced did equally well. So just going through the process, not replacing the plasma, they had very significant benefit in both objective and data and symptoms, but it was a crappy study. And so, it's curious. They were very surprised when their so-called sham group had quite significant improvements. I have a theory as to why that may be the case, but that's beyond the scope of what we're talking about here.
Yes. Thank you. I believe this was suggesting a link to the research paper maybe that I spoke about in your introduction. And if correct me if I'm wrong, Marla, but she mentions, is it possible to get a link to the research paper? And I'm assuming she's talking about the one from 2018.
Yeah, the Journal of Scleroderma and Related Disorders. You have the link. It's on the website. I can, anybody who emails me, I'll send you a link to the paper. It's open access. All you do is you click on the link, you get to the paper. Interestingly enough, that paper is, as near as we can tell, it's the second most widely read paper in that journal's history. Kind of interesting.
Yeah.
For a long time, it was the most widely read, but there's a lot of interest in something called IL-6, and especially because that gets into COVID, perhaps. But in any case, it's readily available just by clicking the link. Remind me to comment on COVID at the end, Tina.
Your DLCO improved. Was that a result of decreased GERD and silent aspiration?
I have no clue why the DLC improved in terms of mechanisms of action. We were just able to document that over a period of years, the DLCO slowly returned and went to normal. And since I was playing soccer or tennis every day, we haven't bothered to look at it since. But the mechanisms we don't know. This gets into the really interesting issue. If you're a smoker and you stop smoking, lungs will heal over time. The mechanisms, I don't have the knowledge to explain why that happens. And I'm guessing that like the GI tract improvements are the GI system pretty much gradually rebuilding itself after either HSCT or if we see this again. One of the patients that's on the protocol is dealing with something called watermelon stomach, and they're closely looking to see whether that improves with this protocol. So I'm going to be fascinated and see if there are improvements in that, because that would be pretty strong objective evidence that the GI tract can heal with the protocol. But it's too early to tell. She hasn't been on the protocol that long, but that's one of the things that I know her doctor is monitoring.
Thank you. This sort of goes into what you kind of already talked about, but just in case it hasn't all been covered, was there ever any mention to changes, improvement in skin tightening or fibrosis?
Skin improvements were common in the research, but in my case, and this patient two was early, very early stage, and she did not have skin changes yet. I have centromere antibodies, and one of the things that is missed by a lot of general rheumatologists, many people are told that they won't give you a diagnosis of scleroderma because your skin looks fine. And first of all, that's not a requirement for formal diagnosis, as any scleroderma expert knows. But if you actually look at the antibodies that occur overall in systemic sclerosis, roughly half of people who formally are diagnosed have an antibody where skin changes are, in early years, are pretty uncommon. And centromere is one of those. So I never developed skin changes, but I was pretty early in diagnosis, and I would guess that the majority of people at my stage of the disease have little or no skin changes. I do have mildly abnormal nail fold capillaries, but I never reached the point I never had digital ulcers or any skin thickening. But it is commonly mentioned in the research literature that people did see improvements in skin. That was a common marker that was used in many studies, especially in the early days.
Thank you. Would someone who has already undergone HSCT, stem cell transplant, and has relapsed be a candidate for TPE?
Good question. And I'm actually working with a patient right now who's trying to make that exact decision. So I'm going to step out of my area of expertise. One of my co-authors is just retired immunologist, world-class immunologist. He did some of the early key research on HIV. He did SARS research and so forth. And the question came up about repeated HSCT. Now, this patient is one who said, I don't care that it worked for a while. I would never go through that again. And I've certainly talked to a number of patients at conferences who've made that same comment. It's a very intense protocol. But his comment to me, and I'm not an expert, he said, if you look at HSCT, there's a lot of variability in the protocol. Some of the research, especially the earliest, did what is called fully myoablative, which means they really, really tried hard to kill off completely your total immune system. Whole body radiation was used, which puts you at risk for longer term stuff and things. And in a lot of those studies, you would see mortality rates from the treatment in the 10% range. So it was not something mild. Because of those, a lot of those were people with heart conditions, it turned out. The protocols that are now used are, I'll use milder in air quotes, they are partially myoablative. So they don't totally kill off. They may not involve whole body radiation in some cases, but they certainly kill it to a great extent. And that's, I think, my belief is that's more common in what is used now. According to this immunologist expert, he said, if you do HSCT using a partially myoablative version and it fails and you repeat it, it will fail again. That was a flat comment from him. However, if you go from fully or partial to fully myoablative, you have a better chance that it might work. but you're also increasing your risk of long-term issues. So that's about, so basically TPE, because of the safety risk, seems to be, in his opinion, it makes total sense to try even before you try HSCT, but if you're rapidly progressing, it is a now considered standard of care. And so I'm not at all suggesting that myself, but there are no contraindications directly that I can think of for someone trying this if they failed HSCT.
Thank you. We're going to be running out of time pretty soon, but I want to try to get to some of these questions. How will this treatment interfere with medications that people are already taking?
That is an excellent question. And the answer is, when you go through a single TPE treatment, on average, about 66%, 2/3 of whatever is circulating in your plasma is removed. 1/3 of it is still there, but 2/3 are gone. That's with the kind of protocol that's usually used. And as I mentioned, a lot of the stuff returns pretty quickly, some doesn't. But that means you do not want to take a medication which has gets into your bloodstream in 2 or 3 hours. You would not want to take that at 8 a.m. and have a treatment in 3 hours if your peak blood load is 3 hours later, because you're going to lose 2/3 of it. So what somebody who is starting this, you talk with a doctor and you may time your medications so you don't see that effect. So that's with short-term things. If you're, I just had a discussion with them on rituximab, which is done twice a year, Rituxan. With that one, what you have to look at is that the peak plasma loads can take longer. And again, this is way out of my league. But if you are doing certain things like that, remember the protocol for TPE is 1 week for 4 weeks, followed by an 8-week rest. You do need to think through what's happening in the plasma just to make sure you minimize that. So if you do the TPE cycle 4 and then do the rituximab, you got 8 weeks before you're going to go back on it again. So it should be out of the system by then, is what he told me.
Okay, it sounds like that it's important that this is carefully discussed with the rheumatologist that's going to be involved, because a lot of this is above the scope of somebody trying to figure out how many of their medications, how long it takes to, go through their body. So depending on the release of it. So I think it's really important that if anybody's ever considering it, that their doctor is on board and that they're going through this with them very carefully to make sure that that's not an issue. So thank you.
Yeah, I had concern with that myself, and there was a medication I was on that I knew had about half-life was a few hours, and originally I had my treatments in the morning, a couple hours afterwards, and I could tell on that medication after a while that it wasn't working as well, and we figured out that's why, and all I did is I switched my treatments to the middle of the afternoon, and I take the medication in the morning, no problem, works great. So it is something that needs to be thought through, and many clinicians contact me if they're looking at thinking about it, and I'm always happy to kind of discuss these kinds of issues with them. But it's mentioned in the guidelines document that we have for clinicians.
Okay, thank you. Where did it go? What is the difference between TPE and plasma protein treatments?
I don't know what a plasma protein treatment is, so I can't answer that. I have no idea.
Maybe he's saying PPE? Maybe isn't there TPE and then PPE?
Well, PPE is a term we're starting to introduce, just a shorthand for pulsed plasma exchange.
Correct.
Rather than doing pulsed therapeutic plasma exchange. We're starting to use PPE, and we've got a follow-on paper, my case report we're working on, where we're going to kind of introduce that term formally. But I have no idea what that particular is. There is a procedure called extracorporeal photopheresis, and if that's what they're asking, that's a similar kind of thing, except that the blood is is treated, and the white blood cells are given a chemical where when you expose the blood to light, it kills them off. It's used differently. It actually can show benefit in scleroderma. There's several studies that show it. but nobody wrote one of the 6 papers that studied that has any idea why it worked. And I had a very interesting discussion with one of their scientists at the company a few years ago with a theory as to why, and it may be a side effect rather than the direct effect. But
Thank you. I got 2 more questions, and we only have 2 more minutes, and I want to open the floor to all of our members to chat. So let's see, where am I? I apologize. I think you sort of already covered this. This might be the same as the other. What is the mechanism of how TPE improves GI issues? Do you know? You said yourself that your GI issues improve. So is this something that's proved on TPE? And if so, how?
This was not discussed in any of the 46 studies we reviewed. And if you think about it, from what we saw and also the HSCT data, where this takes a long time, if you're doing, a short-term protocol, you're not going to see GI improvement. So I'm not surprised by that at all. My hypothesis is very straightforward. I think this is interrupting the damage to the endothelium, and basically, just like what HSCT does, your body just slowly heals if you're not stressing it with further damage, because you have no further stress. And how the GI tract heals and regrows, way beyond my pay grade.
Okay, thank you. What about, would this be a good treatment prior to major surgery to reduce scar tissue formation?
It's a good question. It's probably independent. One of the things that I would have to believe is that if, I don't think you can reverse certain kinds of scarring, but again, I don't have the expertise to comment on what kind of lung functions would improve and what wouldn't. But that's a good question. I honestly don't know. And I think one of the key questions, if it turns out that this works when we get better trials and people start using it, these kind of issues will be looked at long term, and we'll figure it out. I'm personally of the belief that certain kinds of fibrotic damage that's extensive, it isn't going to do much to recover. I mean, obviously, if you had a finger, you lost a gangrene, it's not going to regrow unless you happen to be a salamander, but then it would. One last comment. I know you're going to stop in a second. I just wanted to mention, nothing related to this, but interestingly, I'm actually co-authoring a paper with this immunologist I mentioned on the use of therapeutic plasma exchange as a treatment for COVID. And it turns out there's a logical reason why a combination of COVID with infusion of virus neutralizing antibodies may be a very effective treatment. And actually there's 5 published studies so far and 4 clinical trials on board. Anyway, so we've got a paper that may be getting submitted hopefully next week, and I'll let people know. It's not related to this, but TPE, as I said, is a widely used procedure, but it may actually have a role in treating COVID, interestingly.
Yeah, that would be great to find more out about that. My last question, was there any improvement of calcinosis or sclerodactyly? And again, I think you sort of went over this, but just in case, did you have somebody with calcinosis that might have noticed an improvement?
Interestingly, I didn't see any of the studies talk about calcinosis. You should logically see that. Very few of the studies were long-term, and that's a question I've asked, and my answer is, I don't know. We don't have any evidence. Theoretically, if it's working the way we think so, yes, it should stop or reduce further calcinosis. In terms of existing, I doubt it would do much, but if it, we know that it improves digital ulcers, which are nothing more than the severe Raynaud's, by the way. And so we know that the processes for calcinosis are a bit different, and I don't fully understand them at a molecular level, but my guess is that it should reduce or eliminate future calcinosis, but I can't imagine it would do it terribly much for any existing. That's just a guess.
Great. Thank you, Ed. I really appreciate it. And, if you can continue to keep us updated on this information, it would be great. And maybe as you continue your research and you are working on that paper and you're getting more published, we'd like to maybe have you come back and do sort of an update with us. How would that be?
Always happy to do that. And I will suggest, here's my one commercial. Anybody who's interested, if you're not familiar with the Scleroderma Education Project website, we think it complements the Scleroderma Foundation information. It goes into a lot more depth on a lot of things. So I think those are two websites. If you go to that and sign up on the homepage, you're automatically notified whenever we do any new blog posts, articles, changes, and it goes to no third parties and things like that. So that's the easiest way to keep notified of anything we do. It will be announced and discussed on the website, and you'll get an email about it.
Okay, what about if anybody has any questions that went beyond today's meeting? How would you like that to be answered? Would you like them to send them to me and I can share them with you? What would you like to do about that?
Two different methods there. If somebody if you can consolidate a group of questions and send it to me, I will give you a written consolidated answers that you can just send out to people. On the other hand, people can freely contact me with one of the two email addresses there, either through University of Wisconsin or the Scleroderma Project. Feel free to contact me at any time. I work with patients constantly. A lot of what I do actually is related to in antibody testing, which is an area I have expertise in. We've talked about maybe in the future doing a presentation on that. It's an interesting topic that is well worth learning more about. So.
Okay. Well, great. Well, thank you again for your time today, Ed.